Okay, can everyone hear me?
Yes, it's okay.
Awesome. So, good evening or good morning or good afternoon, wherever you might be, and welcome. This is Keith Boone. I'm going to be presenting today on the SANER project and talking to you about measuring situational awareness using the work of the FHIR SANER IG. So briefly about me, I'm the technical lead for the SANER project and enterprise architect for Audacious Inquiry. And I have been involved in standards development in both HL7 and integrating the healthcare enterprise. For over 15 years, I've been involved in standards for over 2 decades. And been the editor of over 24 standards and implementation guides. Over the last year, I've done 3 using FHIR and have worked on others using FHIR previously. What we're going to cover in today's slides, talk a little bit about the FHIR SANER IG and how it works, and how you can use it to exchange situational awareness data for emergencies such as the current COVID-19 pandemic that's going on internationally. We'll talk about the different information systems and operations that are supported by the FHIR SANER implementation guide. We'll show you a real-world, implementation of an automated report that was developed to basically show how some of what's currently being reported in the US could be done using SANER. And then give you some instruction on building measures and show you sort of the internals of what an automated measure looks like. So before we get started, one of the things that I'd like to do is go through some definitions with you. So what we've got for definitions, first of all, what does SANER stand for? And SANER stands for Situational Awareness for Novel Epidemic Response. That was the title of the proposal that I wrote initially, and when I realized the acronym was SANER, I was thrilled because one of the things that I had been learning in March when we started this project at Audacious Inquiry was some of the insanity that was going on in terms of having to collect all of this data, capture it, manually collect it on paper forms, transfer that data into spreadsheets, upload that into various information systems for, response at the state level, and then separately in other systems for reporting up at the national level. And to me, this was insanity. So with FHIR APIs, we can do this a lot better. We should be able to automatically capture a lot of this data, make it simpler for people to collect it, and then be able to report it to the various information systems that need to receive it. Now, situational awareness, simply defined as sort of having an understanding of what's going on around you. But in emergency response, situational awareness is really a term of art that is expressed and defined using another term of art, essential elements of information. And it's about being able to collect and get and operate with these essential elements of information that you need to have in emergency response situations to be able to handle the logistics of taking resources that is emergency response or public health official you have available to you and getting them to the places that they need to get to so that they can be deployed and used to help alleviate the emergency. So if you sort of Google essential elements of information or EEI, you might see some broad definitions of EEIs. And typically, as I said, in the emergency response space, as opposed to in the healthcare space, and they cover a broad variety of topics, things like transportation, infrastructure, communications, command and control, as well as healthcare. And for general purposes, emergency response, essential elements of information are about, well, where are our hospital facilities and what's their operational status? Are they taking patients? Are they not taking patients? Are they on diversion? Do they have a helipad? Do they have a burn unit? Very underspecified, especially in the context of dealing with something like the COVID-19 pandemic. What these essential elements of information do and what they communicate are different measurements about healthcare facilities or healthcare provider organizations in terms of what's their capacity to respond to the emergency, how much of that capacity is in use, how much of that capacity is available, what's going on today, how many different kinds of important events are occurring, how many patients are infected today, how many patients are in my hospital today or have been admitted today, how many patients have been tested today, how many patients tested positively, how many patients died today, and not just today, but also cumulatively over time, so that you can actually look at growth rates in this particular realm. And then you're also going to look at queue lengths. How many people are waiting for service? How many people are waiting for a bed? How many people are waiting for a test? How many people are waiting for some particular thing to happen? And if you're looking for how many are waiting, maybe you also want to know what's their average wait time, or what's the 90% response time. And then you might have things that don't fit into any of those first four, but where you can at least specify a category, where you might say, I'm in a red, yellow, green status, where red, yellow, and green might mean different things in different contexts, or I'm completely run out of certain kinds of PPEs, or I have a 1 to 3 day supply, or 4 to 7 day supply, or a 2-week supply, where you can fit something into a categorical bucket, but where a number doesn't necessarily provide all of the essential meaning. And as we look at, for example, PPE, it depends. It's not just your quantity on hand, but how fast are people coming in? How fast are you using it? What other measures are you taking to make it last longer, etc.? So there's no one formula to say, well, if I have the capacity to support this number of patients and I have this many caps, gowns, and masks, how soon am I going to run out? So you actually have to have somebody tell you how many days supply are left. And so you need a categorical way to count the number of facilities that are on short supply, have an immediate need, maybe are good for 2 weeks, and maybe have a completely adequate supply, or perhaps even an oversupply. So for each of these different types of measures, you're already measuring these kinds of things today in your development of applications. So if you look at a typical web application, right, you're deploying that, you're looking at um, uh, how much CPU or memory or disk storage are being used by those applications. For your events, right, you're keeping track of errors that are happening in a log, or you might keep track of bugs that are reported or support requests. If you've got a blog, right, you're counting search hits. These are all just event counts that you can look at over a particular period of time and then get cumulative results so you can sort of see how your growth goes. Queue length. You do this in web applications all the time. You're looking at how many people are waiting for a database connection, how many people are waiting on a network socket or a particular lock. Again, looking at this in the healthcare context, how many people are waiting on a bed, how many people are waiting for a particular test. Service times. If you've got a web-based API, you're going to look at your average response time. You're going to look at your 90% response time. You want to do the same thing in the healthcare setting. Understand how long does it take to get into a bed? How long does it take to get tested or to get a test result back? How long does it take to get treated? How long are you going to stay in the hospital? And then, what's the facility status, say, on PPE or whether they're admitting new patients? So this is stuff that you already know and use in application deployment. You can just think about how you might apply that if you're operating a hospital. Once you have these measures, once you've computed these particular values, you're going to need to communicate that. So we're going to look at how this sort of workflow works. And it starts with the public health and emergency response agencies, defining those measures of the essential elements of information that provide the critical information enabling them to make decisions about deployment of resources. So they'll define the measures, and then hospitals and other healthcare provider organizations, clinics, pharmacies, et cetera, will be able to look at those measures, collect that data locally from relevant information systems. And by relevant information systems, you might have your EHR, your ICU central monitoring system, your bed management system, your hospital equipment management solution, your laboratory information system, or your LIS, workforce management, ICU central monitoring. All of these might collect different pieces of data that public health and emergency response wants and put that together. That can be used inside the local facility for command and control activities within the facility so that the facility can understand its needs. Those can be reported up to local public health to basically communicate that information to local public health and emergency response officials. That data can then be reported up at a regional level, say a state or territory. And then from there, also reported up nationally. And the point of communicating these things as measures is that the subject of the measure is a particular facility, which you can think of as a location, and then you can have a local area that's just a bigger location, and then a state or a territory that's just a bigger location, and then a nation yet one more larger location. So all of this data can be aggregated up as it's shared up to the next level. And then that information can be shared as is appropriate at the local level, at the regional level, at the national level, and also be used inside the facility to help manage the activities within the facility and see what the specific needs are internally within the facility. So if we take a look then more at a more technical, the different information systems, you have something that the SANER IG calls the measured definition source. That's an actor that basically publishes measures, right? The fire measure resource. You have the measured definition consumer, which is something that consumes those measures. So basically, it talks to a measure definition source and it issues a query for a measure. Then you have the measure sources, some of which can be automated, others which can be perhaps a little bit more, um, you know, uh, less automated. Still, I would say some automation, but not able to immediately read the measure and automatically compute the values. Somebody would actually have to look at the measure definition and write some code, build a query um, to actually report out the data, but something that could be relatively simply done. You have potentially some infrastructure and intermediary that's able to collect data from multiple sources and aggregate it together. It might be the SANER server inside the hospital, or at the local or regional level that's aggregating data and reporting it up to the next level measure consumer. And then you have the measure computer actor, which has a measure definition consumer and a measure source set of capabilities so that it can report measures and it can consume the measure definitions. It's able to interact with data sources, and these are just basically fire servers or something that has a fire API built according to a well understood national model. So in the US, that would be the US core. In Canada, that might be the Canadian core. And in India, there's some work that's being done to develop national standards in India. And throughout various countries in Europe, just about everybody's defining sort of their own set of national level fire specifications. So as long as you know what the specification is, you can write the measure against that national specification, build queries that can be automatically computed, and the measure computer is not limited to talking to just one server, right? You could have an infrastructure that just deals with laboratory information and is storing laboratory information in a particular data source, and that might be where you get all your lab reports at a national level. And the measure computer in the hospital might be able to query that as well as query the hospital's EHR system and collect data. Now, as we noted on the previous slide, some information systems, are fire enabled. You can do fire queries against them, and they can be data sources that a measure computer can operate with. But other information systems that are perhaps close to the data that you need to get to may not be fire enabled. And so if you think about ventilator usage, right? If you have a busy ICU, multiple patients crashing, doctors yelling out intubation orders to happen immediately, and everybody's rushing to get the patients intubated and stabilized. Well, those orders might not be recorded in the EHR until the end of the shift, or perhaps even after that. But that central monitoring station, as soon as that ventilator's like turned on and operating and sending telemetry to the central monitoring station is going to say, well, okay, well, that ventilator's now in use. So it's going to have a more immediate knowledge of what's going on, and might be a better measure source for ventilators that are available. Similarly, in a lot of hospital environments, the EHR is integrated with a bed management solution. Well, that bed management solution may not have seen any fire love. It may not have fire APIs available. And the EHR is in fact integrated using an HL7 version 2 ADT interface to be able to figure out where the next bed's coming from in an ICU or elsewhere in the hospital. So that bed management system is probably the source of truth that you want to integrate with. Well, how does SANER support that sort of capability? So if we look at that, the lowest common denominator is that each of those information systems probably has some sort of database underneath and a way to query that database. And if it's got a database and a way to query that database, it's probably got a way to put together something like a comma separated value format file with specific column headers. So what SANER does is says, well, okay, if you gave us a CSV and told us which column headers fit into which fields in the measure report that you want to produce, we can map it into that measure report. Go ahead and create that and transmit that or store it, depending on whether they're doing push or pull capabilities. And you might have to specify some extra data about what the period is for the measure, who you're reporting on behalf of, or what the specific subject is of the measure, or how to map the columns. But the bulk of the data would be just in that CSV file. So we have operations that are defined to be able to deal with translation from CSV into the measure report resource that's defined by the IG. And then just as all measure sources are not created equal, then you've also got different kinds of measure consumers. Right? You're creating dashboards and visual displays, maps, and all sorts of pretty user interfaces using tools like Tableau. Well, they read CSV format fairly readily. But honestly, do they know anything about fire APIs? Well, probably not. So just as there are ways to create the measure report in CSV and map to CSV, there's also ways to read a specific report back in CSV format so that this mapping is reversible, and then search and collect data as well. And so these read CSV and search CSV operations are patterned pretty much after the read and search HTTP operations defined for FHIR. So what SANER does is it provides a complete reporting approach. You have the capability to get data from bed management, ICU central monitoring solutions. You have a way to have, say, a Smart on Fire based application, look in a measure, query data from the EHR, get that data back and compute measures. And then you have a way to aggregate all of that data, use it for local command and control, and then report it out to public health and emergency response agencies. So let's take a look There we go. Sorry about that. I realized I hadn't started my video. Let's take a look at what it takes to go ahead and automate some measures. And to start off with, we'll talk a little bit about languages for automation. So if you think about measures and say you wanted to know, oh, how many patients do I have in an encounter with COVID? You know, if you looked hard enough, you could probably write a simple FHIR query that would get you the set of resources that you needed for that. It would be a pretty gruesome query. It probably wouldn't be supported by many information systems unless it was, you know, literally and you know, sort of off the shelf, one of the open source or commercially available FHIR servers. So you might need something that is able to do this a little bit more directed and algorithmically. And so you'll need a language to describe the measure. And so we looked at FHIRPath and the clinical quality language. And what we decided was that the different groups are going to determine and decide on one or the other, depending on what's available to them, what capacity they have to implement, what sort of funding they have. So we didn't decide on one or the other. But we did look at FHIRPath, and one of the things we found with FHIRPath is that there are multiple platform implementations available. It's available in JavaScript. It's available in .NET. It's available in Java. It's available in a number of different platforms. But when you write a measure in FHIRPath, it's not always very easy to read. And we've done some work to simplify that for some folk. Whereas clinical quality language, sort of as an emerging language for not just clinical decision support, but also clinical quality measurement. Much easier to read, but also much more limited in terms of availability of implementations. Now, interestingly enough, these two things evolved from different places, but they wound up converging to the point that FHIRPath is now a subset, a formal subset of CQL that's actually defined in the clinical quality language. And so FHIRPath itself is a separate specification, and then the formalization of it as a subset is defined in the HL7 clinical quality language specifications. So if we went back to that early slide, you would see that that first slide that showed the measure, one of the things that was of interest was the number of beds occupied in the hospital, the number of ICU beds that were occupied, the number of non-ICU beds, and the number of other beds. That particular form was not written in that fashion. It was written in a slightly different fashion. But if you were to give somebody the total number of non-ICU beds occupied, inpatient ICU beds occupied, and other beds occupied, everything that they wanted about bed occupancy on that form is computable from a measure that is broken down in this fashion. So the first thing that we would do is basically count the most recent location in the most recent encounter for each patient where the encounter is in progress or finished within the period. To do that in FHIRPath, we're going to cheat a little bit. I'll show you how we're cheating on the next slide. But the first thing we want to do is we want to query FHIR servers for encounters We want to include the subject of the encounter, that's the patient. We want to include the condition associated with the encounter or the reason associated with the encounter, because we're going to use this other data for subsequent measures. Where the status is in progress, and where the date is within the reporting period. And so, maybe this needs to include where the status is equal to in progress or finished in this particular case. And so what this first function would do would be go off and construct that query and then go issue it against the servers that are specified in the base parameter. And that would produce a number of FHIR resources to which the aggregate function is then used to go off and find the locations within those encounters. And if the location is already present in total, just return total, but is not already present in total, then add this location to the total. So this is basically just going to aggregate all of those locations. And at that point, you now have a list of beds. And if you count the number of elements in that list, that's the number of beds that are occupied. That's the total number of beds. That's all the beds that are in use. So the location associated with the encounter basically tells you the locations within the facility where patients could be, and that would essentially be the beds. The next step is to take that list and to stratify it by the type of location. And so if we have this list of location resources, then for each one, we can look at it, we can get the type, and then we can go see if the type is a member of the non-ICU value set. And if it's a member of the non-ICU value set, then we set the stratifier for this particular location to inpatient non-ICU. And if it's not a member of that value set, then we look to see, is it a member of the ICU location value set? And if it's a member of the ICU, then it's inpatient ICU. And if it's not either of those, then we could put it into the other bucket. And the measure computer would go and take each of these locations, evaluate the stratifying expression based on the context of the location, and essentially produce a count of the number of beds occupied for inpatient non-ICU beds, inpatient ICU beds, and other beds. Okay. So I'll just sort of quickly scroll back to this here, and you can see now that we now have the capacity to report the number of patients with suspected or confirmed COVID who are in the emergency department or any overflow patient awaiting an inpatient bed. That would be the other bed category. We also have the ICU bed occupancy, right? So this is the number of ICU beds that are currently occupied, right? And then all hospital beds is the combination of other ICU and non-ICU. So it's perhaps a little bit different reporting, but the information about all hospital beds is available now in that one sort of measure. And hospital inpatient bed occupancy is that inpatient non-ICU bed sort of number. So we've managed to capture 1, 2, 3, 4 different values with one computed measure and stratification. And you could do similar things with ventilators. And then you can take those same values, understanding who's been hospitalized, and then look for other evidence to see, well, are they on a ventilator? And that gets you to that hospitalized and ventilated sort of capacity. So once you've built one measure, you can actually take that set of values that have been used and given a name. Total beds up, it's the number of total beds occupied, and you can use that in a subsequent portion of the same measure. Say, well, start with what you got from this and add to that a filtering criteria that says with suspected or confirmed COVID. And so that's how measures would get built. I talked a little bit about, we cheated a little bit in terms of, we wrote this very nice looking FHIR query where we said find all encounters that include all of these particular references with this particular value equal to that, and with a date within a reporting period. We defined something called Fluent Query in SANER that basically says these are the functions that you can use to construct a query. And this is what it evaluates to, is something that already is in FHIR path, where you have the ability to create a URL, resolve that URL, and then select content from that URL to be able to do work with it. And when I initially wrote this code before Fluent Query and I was trying to explain it to people, I realized as folks' eyes were glazing over that it's just not readable. It's not explainable, even though for those of us who work with FHIR queries, that's all perfectly obvious what it's doing. But if I just read the words here, find all encounter, including subject, condition, reason reference, with, status, equal to, in progress, or finished, with, date, within, reporting period, on servers, base. That's almost an English sentence. So much easier to read. It's not a requirement of SANER that you use Fluent Query in measures defined for SANER. But if you want people to understand what you're doing, you probably would want to look at that. So last note, before we get to questions, as you're thinking about situational awareness measures, if you've already done work with quality measures, there's some differences that you need to consider. Situational awareness measures are really about providing the information to enable people to make decisions in a dynamically changing, emergent environment. The information that they need is at a high level for the most part. May not be based on the most well-defined evidence, because honestly, as the emergency is occurring, for a lot of this, we're building this plane as we're flying it. We're learning as we go. So we're giving our best guesses initially, and enabling systems to support change over time quickly. We don't have time to do a 6-month long research study around what's the best data to go collect to figure out where to get resources. Those resources need to be there tomorrow, or they'll, at the best, maybe a week from tomorrow. And so you're dealing with limited information. You're going to keep updating this as you learn more. The data doesn't have to be perfect in order to be able to support this kind of decision making. It needs to get you close, because if you need to be more accurate, basically what somebody's going to need to do is pick up the phone and get the fine details that are understood locally by the officials on hand, who can help them make decisions about, do I send that here or do I send it there? Right? Whereas with other measures, clinical quality measures, you want to be able to deal with fine distinctions. You want to make sure that these are based on well-defined evidence after there's been detailed research, and that this stuff remains consistent over time, so that you can have that accuracy, so that you can have that reliability, and so that you can have that sort of repeatability and be able to do research against this. But if you're talking about an emergency situation that's changing rapidly, you don't necessarily have all of those same opportunities. So as you're sort of doing this, just think of this as an exercise that you can do for yourself. Imagine you have some resource that you have to offer somebody. It might be a resource for treatment. It might be people with skills. It might be PPE. You might have something else. You might have a field emergency medical center that you can go set up somewhere, right? That's your intervention that you're going to be able to supply to somebody who might need it, or to some place that might need it. Now you have to think about how you're going to make the decision about where to deploy that. What do you need to know? And how are you going to figure that out? Right? So who's got the most urgent need? And you have to consider separately who's going to get the most value out of it. And then how are you going to determine that? And the most urgent need and the most value might not be one and the same. You might have a hospital facility that is completely out of resources and is treating a small number of patients. And you might have another hospital facility that's struggling to get by and is going to be out in a couple of days and is treating a larger number of patients. And depending on what resources you have, who's going to get the most value out of it? Well, if it's a small number of resources, providing it to the hospital that's got a large number of patients, it's only going to hold them for another day. Whereas at the hospital with a smaller number of patients, it might do a lot more for them, right? Or if you've got a large number of resources, but you really can't break it down, it's going to be too much for the smaller facility, whereas it's going to be adequate for the other facility. So you have to think about who's going to get the most value out of it. What measures do you need to be able to make that judgment? How are you going to determine that? That's what you have to think about in terms of measurement, and then you design your measure. You don't design your measure first. You have to sort of think about what's the use case, what you're measuring for, what intervention it's going to support, how people are going to use that data, how you're going to present that data, and then you build your measure. All right, problem first, then the solution. So, this is something that you can go off and think about, work through, make some notes, take a look at the SANER IG, figure out how to build this. So I'll come back to that slide and I'll stop here for questions. Oops. So, folks have questions? Okay, so obviously this project responds to a global need. Do you know if other countries have implemented the SANER implementation guide? So I've had some discussions with folks who have been looking at this work. Some folks in the UAE and the Middle East, others who have had some interest in India. Haven't particularly heard about any specific implementations as of yet. Right now in the US, we're just embarking on our first pilot, which is enabled through one of the ONC STAR HIE grants that is supporting public health in the state of Texas. And obviously interested in international uses. And when we originally presented these materials to HL7 work groups and steering committees, it quickly became apparent that this is an international need. And so many of the companies who have been working with us are working globally in this, but I can't speak to any specific international implementations to date. We're just getting started with pilot implementations in the US. So do we have other questions? Okay, so let's just go back and summarize what you learned. So we talked about what situational awareness is, and it's communicating essential elements of information. These EEIs are key measurements to assess and respond to an emergency. Multiple systems have EEIs, and not all of them are going to be FHIR enabled. For those systems, you can convert from or to CSV, and you can automate measures and computation of measures using FHIRPath or CQL. So I'd like to thank you for attending this presentation. You can, if you've got further questions or want to learn more about how you might implement this, you can email me